Lovely.
Great. So good afternoon, everyone. It's a pleasure to be part of this year's Ask About Asthma Nursing webinar. I'm Maddie Jeffries, a physiotherapist working as part of the difficult asthma team at the Royal Brompton Hospital, part of Evelina, London and Guy's and St Thomas's NHS Trust. Today I'll be talking about dysfunctional breathing, specifically within paediatric asthma. And I'd like to just start by giving a special mention to Charlotte Wells as a co-contributor, as well as to the broader Kids Cornerstone Collaborative for their immense research and work in this area that I'll reference throughout the presentation. So today, by the end of the session, hopefully you should be able to define dysfunctional breathing, specifically in children and young people with asthma. Then outline the evidence base that supports physiotherapy for children and young people with dysfunctional breathing and asthma. Explain the key features in recognising dysfunctional breathing in specifically difficult asthma as well, including clinical history and assessment. And lastly, to describe the everyday management strategies that can be implemented at any level of asthma care for dysfunctional breathing. It's worth saying this presentation is not designed to give a comprehensive level of training for the assessment and management of dysfunctional breathing, but if you are interested in developing your skills, either pop a message in the chat or I'll leave some details about courses you can attend if interested. Here is some common abbreviations that we'll use in this presentation. You may wish to scan this code and the abbreviations will come up one by one on your phone. I'll just give a moment for everyone to do that now if they'd like. Fine. All right, so what is dysfunctional breathing? By Hepworth and colleagues, it's described as a change in the normal biomechanical breathing pattern, which causes intermittent or chronic symptoms. Dysfunctional breathings typically can mimic or amplify symptoms of asthma. There are variations in this definition across the literature, along with no clear consensus on what it is called. Today I'll talk about dysfunctional breathing. However, you might also see this clinically or in the literature as breathing pattern disorder, hyperventilation, or hyperventilation syndrome. Now, dysfunctional breathing is multidimensional, and optimal assessment and management requires a holistic approach. Rose Albert in 2017 originally described the 3 dimensions of dysfunctional breathing, including the biomechanical dimension, so the changes in the breathing pattern, and prolonged structural changes in the musculoskeletal system, as well as biochemical dimension, which is the alteration in normal blood gases, for example, hypocapnia secondary to hyperventilation. And lastly, the psychophysiological dimension, involving emotional aspects, anxiety, stress, and thoughts around triggers. Sinapa and Wells later described a 4th dimension, being medical, considering the effects of pulmonary, cardiovascular, and metabolic diseases that may cause an alteration to the breathing pattern and perception of breath. The disruption of an optimal breathing pattern can contribute to distressing and debilitating symptoms, including breathlessness, chest pain, chest tightness, and signs of air hunger, such as frequent sighing. These symptoms can be worsened by exercise, stressful events, or anxiety. Physiotherapy intervention considers each dimension with the aim of developing a healthy, efficient, and effective breathing pattern. So, dysfunctional breathing in asthma. Hepworth found specifically that 35% of patients in their paediatric asthma clinic had dysfunctional breathing and concluded it as a clinically relevant comorbidity in paediatric asthma. A previous local service evaluation here, completed by Wells and colleagues, found that of those attending our specialist tertiary DA clinic, that 65.3% of those assessed by a physiotherapist were found to have dysfunctional breathing. So what is the evidence? What does the literature and the guidelines tell us to support physiotherapy for children and young people with dysfunctional breathing and asthma? BTS and SIGN, GINA and NICE asthma guidelines all recommend physiotherapy for children with asthma, particularly dysfunctional breathing. Multidisciplinary asthma services are encouraged. The NICE Quality Statement 11 on pediatric difficult asthma, and BTS guidelines give a grade A recommendation for physiotherapy intervention as part of non-pharmacological management. The physiotherapist's role within the specialist multidisciplinary asthma service is to help identify contributory causes of persistent asthma symptoms despite medication optimization. Not only disordered breathing patterns, but also poor fitness, exercise-induced laryngeal obstruction, and to manage comorbidities such as chronic cough or airway secretions. Physiotherapy services for children and asthma and/or dysfunctional breathing have been demonstrated to improve asthma symptom scores. And Barker and colleagues in 2016 suggested that breathing retraining appears to offer significant benefits to children and adolescents with dysfunctional breathing in terms of quality of life and symptoms experienced. Unfortunately, benchmarking of difficult asthma services in the UK by Wells in 2017 found that 89% of DA services did not have funded DA physiotherapy, with 66% of physiotherapy services having no set hours for asthma services. So how can you recognise dysfunctional breathing? Dysfunctional breathing can be observed as upper chest breathing, irregularity in the respiratory pattern, excessive sighing, mouth breathing, higher respiratory rates as well. It can mimic or amplify asthma symptoms, as I've already mentioned, most frequently evident as exercise-induced dyspnea and chest tightness. Symptoms of dysfunctional breathing in children can include breathlessness, chest pain, chest tightness, signs of air hunger, and these symptoms will be worsened with exercise. The importance of careful history taking and assessment to differentiate between dysfunctional breathing and causes of asthma or asthma-like symptoms is key. A detailed history and appropriate investigation of common and uncommon non-asthma diagnosis should not be overlooked, including EILO and dysfunctional breathing, but also other red flag conditions, as shown here as part of the Tier 3 asthma capability training and by Hull and colleagues in the BTS clinical statement for the assessment and management of respiratory problems in athletic individuals. Systematic multidisciplinary assessment of children and young people with asthma will ensure that all of the key appropriate causes are considered. Key clinical features synonymous specifically with dysfunctional breathing might be variable time for symptom onset. So this could be at rest, immediately with activity, or afterwards. And so they may be episodic or persistent. Specific difficulty with the inspiratory breath might be described, or difficulty catching their breath or feeling like they can't get enough air in. There might be symptoms of hyperventilation, being dizziness, blurred vision, pins and needles in the hands, or tightness around the face and mouth. And really quite specifically, the child or young person may not respond to short-acting bronchodilator therapies, or this response might be highly variable. When we look more closely, this detailed history, including triggers and symptom onset, allows clinicians to decipher between the cause of asthma or asthma-like symptoms. Specific key differentials being EILO, exercise-induced bronchoconstriction or exercise-induced asthma, or dysfunctional breathing. This is well described by Wells and Sinapper and colleagues here, and by Hull and colleagues here in the BTS clinical statement. Now, I'd like to involve everyone in a quick self-assessment. I would welcome anyone to turn their cameras on if they feel comfortable, and if that's available, then just for this exercise. In a comfortable sort of seated position, place one hand on the upper and one on the lower part of your chest or stomach. Tune into what you can observe about your own breathing pattern. Are you breathing through your nose or your mouth? Can you hear your breathing? Is it loud or is it quiet? Are you breathing to the top of your chest or down to your stomach and lower ribs? Is there a gentle rhythm to your breathing? And how are you sitting or standing? Are your shoulders round or is your chin forward? Understanding the elements that make up an effective and efficient breathing pattern can help us identify when things go wrong. Structured observation of the breathing pattern along with palpation, movement analysis, both at rest and when provoked, is integral to our assessments as physiotherapists. But these signs might be obvious within your clinic. In optimal breathing, the breath is quiet and goes in and out through the nose. The rate is regular, rhythmical. Each breath is similar to the last in volume. And breathing is diaphragmatic, with movement seen in the tummy more than the upper chest. Absence of regular sighing or other bad habits that might be coughing or throat clearing, versus an altered breathing pattern, which may include predominant mouth breathing into the upper chest, yawning, sighing, noisy breathing with an erratic rhythm, judders, breath holding, just to name a few. So what can you do day to day within clinical practice to help manage dysfunctional breathing in children and young people with asthma? So don't forget the basics. Optimize asthma management. So this is pharmacological therapies, so inhalers, adherence to these inhalers and pharmacological therapies as well, the inhaler technique, comorbidities, any red flags, the personalized asthma action plan, and education. Don't overlook the importance of the asthma review, especially after an attack. And this is as per asthma guidelines and in line with the National Bundle of Care for Children and Young People with Asthma. Then if we think more specifically about addressing dysfunctional breathing alongside optimal asthma and comorbidity management, simple tools can positively affect an altered breathing pattern in children with asthma. Education is key. Age-appropriate discussions about how we breathe is a great starting point. We can explain how we breathe and that breathing in a different way can mimic our asthma symptoms and make them feel much worse. We can incorporate the basics of breathing, including how many lungs we have, where they are, and how do we breathe at rest and with exercise. Next is the sinuses. Our first point of call in physiotherapy and breathing retraining is to utilize nose breathing. Optimal upper airway hygiene, including management of sinus symptoms, is a great way for patients to prepare for physiotherapy input. In addition to humidifying and filtering of air, nasal breathing allows the flow of air to be slowed down and gives better activation of the diaphragm versus mouth breathing. Optimal sinus management may include appropriate pharmacological therapies, including sprays, drops, sinus lavage with NeoMed, or simple strategies such as practicing good nose blowing. Lastly, self-management. So any discussions about asthma symptoms and how the adherence to their medication can affect this, and the difference in this to the changes in the breathing pattern, big emotions, amongst other triggers, aggravators, including exercise, allergies, and the environment. Discuss and separate how these may identify and differentiate the symptoms between each. This can be used to direct their management plans, which can be incorporated in their asthma action plan. If we build on this further, we can introduce the basics breathing control in the form of the good breathing checklist to bring awareness to when an altered breathing pattern or unhelpful breathing, as we call it, might be contributing to their breathing symptoms. The child or young person could be encouraged to practice this for 5 minutes per day when they're well and utilize this when they're feeling their asthma symptoms. The good breathing checklist is also incorporated into several other resources to help children when they have asthma or asthma-like symptoms, including this flow sheet below, developed by Bean. And as mentioned earlier, any breathing control or rescue strategies can be incorporated into their personalised asthma action plan, which you can see here at the bottom as an example. So all of these resources and more can be found on our resource pages. We've got one for children and one for teenagers and young people with asthma and altered breathing patterns. Other helpful resources and information, more so for healthcare professionals, including upcoming courses, can be found at the physiotherapyforbpd.org.uk website as well. So that's all I've got for you today. If there's anything more specific you sort of would like to know about dysfunctional breathing or courses or resources, please do send me an email or post these in the chat. And here are my references. Thank you.
Maddie, thank you very much. That was a great introduction to this webinar. As we've mentioned in the chat, we will be taking questions at the end to the panel of speakers. So we're going to move swiftly on now to Laura, who's going to talk very much linked, because we use lots of salbutamol with children and young people with asthma. So talking about the safe use of salbutamol. So Laura, thank you. Over to you.
Thank you, Alison. Yeah, thanks for having me. So my name's Laura King. I actually recognise loads of names from the chat, which is really lovely. Lots of colleagues. So I'm here to talk about safe use of salbutamol and safe discharge in my patch, which is North East London. So as a very, very brief introduction to my patch, for those of you that aren't familiar, we are quite small geographically, but a heavily populated, very diverse area, and a very deprived area. So I'm not going to read all the numbers, but you can see we have lots of hospitals, we have lots of boroughs, we have an insane amount of GP practices. But we also have, as I say, a really richly diverse population, also deprivation, pretty poor health literacy and literacy in general. Lots of people who don't speak English, and incredibly poor air quality. I think possibly the worst air quality in the country. When we think about this in terms of the acute, I just wanted to start with a bit of a demonstration of the sort of stark differences between some of the populations in our patch. So those of you who are familiar with the dashboard for asthma will recognise this, but those of you that aren't, hopefully you can see at the bottom the time series for the year. So this is a demonstration of the acute attendances to A&E. In, I think, just one of our trusts actually, but it's essentially the same across the whole patch between all the hospitals. So you can see, of course, our September peak, which is why we're here for Ask About Asthma, but we also have the peak in May, which is largely related to sort of pollen counts. Above that, hopefully you can see the bar chart, which has some coloured bars which relate to sort of ethnic profile for our families. If you're not familiar with deprivation quintiles, on the left, you won't be surprised to know that on the left is the families with the most deprivation, so those the worst off, and on the right are the wealthiest families. And this is usually gathered in terms of where families live. What's quite frightening is that you can see a very, very clear disparity between our populations who have the most and those who have the least, but frighteningly also based on their ethnic profile, which is quite sad. So essentially in our area and in lots of other areas, I'm sure, if you are a child that is Asian in a family that don't have very much, you are disproportionately more likely to have an asthma attack and have quite worse outcomes. So I'm just going to leave that there and just keep it in mind for the next few slides, which are a little bit of background. Hopefully this slide is very boring for everyone and everyone is already aware of the burden of asthma in the UK, but just as a quick whiz through, it's one of the most common presentations in children in the UK. I think it accounts for about 14% across the whole year, which is really significant. Over 25,000 admissions to hospital each year, which is appalling. And we of course have the highest death rate from asthma in Europe, so embarrassingly quite significantly worse than the next worst country. Hopefully a lot of you are already familiar with NRAD, so the National Review of Asthma Deaths, which was now 10 years ago. And they found that almost 50% of healthcare professionals involved in children who died from asthma actually didn't follow guidelines correctly. And with that in mind, when we consider why children have attacks, if we're not following guidance and we're not supporting families in the right way, we're not consistent, it's really unlikely that those families and those children are going to have good outcomes and manage their asthma correctly. So again, I'm just going to leave you to read the list. It's probably not going to surprise anybody. Poor adherence, poor understanding, of course psychological reasons, because that's usually there in the themes. And sadly still a problem a decade on from NRAD. When we consider risk profiling in children's asthma, again, it's on the same theme. I'm so sorry, someone has just obviously knocked on my door. I'm going to ignore them. Historically, children who are poorly controlled with a history of severe exacerbation are very high risk, as we would imagine, but also having concurrent atopy and psychological issues, it puts you at a really high risk of having a fatal attack. Again, no surprises. Poor parental understanding and social deprivation are high factors. But something that surprised me is that actually the most predictive factor in a severe or life-threatening attack is actually having a severe one before. And again, when we consider consistency and our process when we discharge these children after an attack, it's really important to document really thoroughly and make sure we're very clear in our expectations. This is a table, and it's a very wordy table, so that's why I've summarised on the left. That looks at the themes for 5 deaths of 5 very real children in the last sort of 8 or 9 years. As you can see, these are the themes that are common to every single death. Of course, there are nuances between those children, but generally speaking, unfortunately, the themes are the same. To summarise the very wordy descriptions, as I said, poor understanding of asthma. And that's not just for the families or children, that's for the people around them as well. Schools, hospitals, primary care, sort of everybody not understanding what asthma is. And of course, as a patient or as a family, if you don't want to know what asthma is, you are very unlikely to manage it well. The second major theme is sort of not considering acute attacks as a failure. There seems to be a sort of narrative that it's okay to have an attack. And that's where this whole project came from. We wanted to change the narrative. And then, of course, we've got the sort of, I suppose, the concept that it's a series of unfortunate events and not a long-term condition. Again, we had quite a few children where they attended a frightening number of times to the same department, but it just wasn't seen in series. It wasn't seen in context. And actually, for some children, it flagged safeguarding alerts on the ED system, and they were pinged off because it's just asthma. Yeah, it just sort of sets the scene for where we were at when we started this project. And of course, the usual themes: no review, no asthma plan, poor adherence to medication, poor technique. And then last but not least, for a lot of these families and some of the ones since, just a really poor understanding of what to do in the discharge period, but also when you're in trouble or when to seek help. So some of our children, unfortunately, had out of hospital arrests because the family just simply did not recognise when they were sick. So our plan in North East London, number 1 was to scope sort of the post-attack review process across the patch, but more importantly for this project, looking at the process and the pathways and the resource that we were putting into safely discharging children. One of the biggest projects within this, which is why I'm here today, was scrapping salbutamol weaning regimes entirely in our patch and embedding the safe use of salbutamol in our acute discharge process. We created a pan-North East London patient booklet with all of the brilliant basics together, and in some areas we did pilot an electronic discharge checklist as well. The flowchart on the right is just an example of our process, which we'll talk about in a little bit more detail in a minute. So this work started a long time ago, a good few years ago, and as I've said, been a huge, a huge team effort. We're really lucky. I've got fantastic colleagues, and some of them are on the meeting today, who have contributed to this and led in their areas. Work started in the individual trusts quite some time ago. As I said, I was one of those people that came into a trust in our area following a Regulation 28. And started some sort of small-scale change work in the safe discharge process. So I was the person that went around the departments with a bag and picked up all of the various bits of paper around discharge. As you can imagine, I had quite a lot of bits of paper relating to asthma, various well-meaning leaflets and bits of signposting. They were largely correct, but sometimes not. But again, it just does not foster trust when we are giving different information. Even within the same hospital, within the same trust, it really depended on who was discharging you and where you were admitted to or where you went home from. And I'm sure that was the same across the whole patch, which is what my colleagues tell me. As you can see, the variable discharge processes just don't promote sort of safe, consistent care. And we know that a lot of our families, especially those who have had a difficult time with health and with authority, it does not help trust. One of our wonderful ED registrars did some safe discharge root cause analysis. And again, the problems are not going to be a surprise to anybody. We have sort of flawed information, problems with shared responsibility, clunky IT, I think causes us all a lot of pain. But she sort of looked at that and we broke it down in one of the sites and had a really good understanding of what the problems were. And essentially, humans do not like change. This is a highly embedded practice. And actually, the problems are not always well known. Some of our teams were really surprised to understand that large amounts of salbutamol are actually quite dangerous. So those of you that aren't aware, we've got short-term side effects. So I'm sure all of us who have a background in A&E have had the children who are merrily vibrating in their bed because they've had so much salbutamol and perhaps they're a little bit salbutamol toxic. But also there's long-term risks, which are things like, increased inflammation in the airway, worsening the problem that is asthma, the inflammation, and some downregulation of the receptors. And what we quite often end up saying to our families when they're using salbutamol so much is you do realise that actually when you use it so much, you go for 10 puffs when you don't need to, which is a side effect of the weaning regime because people think you can just give 10. When you need your reliever, it's not going to work. So it's really quite frightening. So back to the project. Now I've ranted about salbutamol. We started the scrap back in sort of 2020-21. Following the regulation 28, just as I said, we actually had a mini step in some of the trusts that we actually first standardised weaning regimes, which feels a bit backwards, but it was necessary. Unfortunately, we had to get things consistent and then start the scrap. The main query is what do we do instead? And luckily for us, Southampton had already done that. So a year before Southampton, maybe 2 actually, they'd started a wonderful resource that was being shared quite widely in the last couple of years. It's a flowchart. There's a link there, hopefully, otherwise I will pop it in the chat, to the paper around their tool. It's a really brilliant flowchart that basically aligns with your asthma plan and gives the family sort of responsibility and the onus to look at their child. Do they actually need salbutamol? And if they do it in a targeted way aligned with your plan. Alongside this, this was of course included. We had a pan network information booklet that we first launched at the London in the Tertiary Centre and then rolled out last year across the whole patch. Again, it's a tricky patch to disseminate information in because, as I've said, we have so many teams. So first and foremost, the beginning of the process, everybody was involved. So we have the stakeholders from our acute trusts, we had our ED leads, we had our asthma teams, we had our acute ward teams. One, to get buy-in, but also very selfishly to gather support because we knew it was going to be tricky. It's a really difficult change to make. We did targeted teaching, of course, and again, we were very cheeky and hooked it onto Ask About Asthma Week. But we also disseminated a video knowing that there's high turnover in A&E, there's high turnover in the wards. You physically cannot get to everyone in person. So we went literally through, we sent a video and we went through the booklet page by page to make sure everybody understood what they needed to do. And I popped in the chat just the link to the resources because we haven't got time to go through it all. These are the key resources. So the asthma action plan, so we use asthma and lung and the booklet. Oh, excuse me, my team just had a moment, clunky IT. And as I said, we've got through to the last bit of the last little bit of evaluation for the first phase. And we've had some really lovely feedback. I know I'm very tight on time, so I'm going to try and be quick. So we surveyed children and families, and I will admit this was largely in Tower Hamlets where we'd had the resource for a little bit longer. Overall, the feedback was actually quite positive. We were really worried that our families would just sort of reject the change and be quite cross. So largely the families found the booklet helpful. A third was sort of neutral, and unfortunately a few hadn't been given anything, which was slightly unhelpful. What we did notice was that our hospital experienced parents, so children and families who had been through the motions lots of times, noted the change, but actually respected it and were happy with it. They found the instructions clear, and that was one of our real worries, that it would sort of be rejected and they'd do their own thing. As you can see, we've got pretty high levels of confidence in looking after their child when we put the onus back on the parents, and generally they did understand what to do with the blue inhaler, which is fantastic. And feedback from clinicians was quite interesting. We had lots of feedback. Some had some quite strong feelings, let's say, about the change, but actually that identified a need for training. So we had a particular area where feedback was quite scathing and quite cross. But actually it boiled down to people feeling unconfident and worried. But we generally had a really strong response around understanding. We had a really strong request for lots of languages, which informed the work. But actually, it really helped. Once we explained to the teams why the change was being made, they respected it, and actually we're really lucky. We had fantastic engagement. Results so far have been really fantastic, and we're waiting for lots of data. But essentially, decrease in readmissions has been seen. We've got a decrease in bed rates and a decrease in admission rates that's quite significant. So we're really excited to sort of see how it goes this year. We've had an increase in patients escalated to the retrieval team, which initially seemed a little bit worrying, but actually that's resulting in less retrieval. So it seems that people are escalating quicker in the acute side and actually sort of turning things around a little bit quicker, which is fantastic. And then you've just got the overall results. Stakeholders can feel confident. Acute teams, know they're giving the same information. And of course, with all of these things, repetition is key. So we're giving the same information everywhere the family goes, which is really helpful. Lastly, I promise I'm wrapping up. Next steps are to collaborate with the wonderful Southampton team to compare their population in Leafy Hampshire to our North East London population, because we're using similar tools. Evaluating the impact, because this is the first year we have the booklet in 14 languages, and we also have some sort of additional resources that I'm just hopefully have pressed enter and popped in the chat. This is just a very, very visual timeline of how it's gone, and I'm sure the slides will be shared. Yeah, that is me finished. I'm just going to stop sharing because I think questions are at the end, aren't they? So let me just stop.
They are, Laura. Thank you very much. For those of us who haven't scrapped the salbutamol weaning plans yet, gives us lots of confidence to make that next step. So we're going to hand over now to Carol, who is going to talk to us about diagnostic pathways, which I'm sure we will all be very interested in, because for many of us, we haven't got access to them. But I'll hand straight over to you, Carol, and then we'll take any questions at the end of your presentation. Thank you.
Thank you. What, can you see my slides yet?
Not quite.
Bear with me. No?
Wonderful.
Yeah.
That's it.
Excellent. Good. Thank you so much. They've been really interesting presentations, and I think they're all really important for getting this right for children. So I am going to talk about diagnostic pathways for children and young people, specifically with asthma. I have a few different roles. One of my roles is that I am the co-chair of the Task Force for Lung Health Early and Accurate Diagnosis Group. So clearly that's one of the things we have on our radar. So we have recommendations for this, and it's worth knowing what the recommendations are, because the recommendations tend to drive change. And the National Bundle of Care from NHS England tell us that ICSs should have developed diagnostic hubs in primary care that have some input into secondary care, so they're not standalone, and that the people working within those are appropriately trained to take a history, make a diagnosis, and or to do the testing and make sure that the testing is consistent. I think part of the problem in primary care, and I have a 26-year history in primary care, is that sometimes training isn't readily available, and sometimes you're told it is your job and you don't necessarily have the skills to support that. What the bundle tells us is the right thing. So it tells us that when we make a diagnosis of asthma, it needs to be based on clinical features, the things we know make it more likely for a patient to have asthma, and that when the child is old enough, then we should be looking for the right objective tests to prove our theory that the patient has asthma. And the thing that the bundle of care tells us is we should be looking at the most recent national guidelines. Now, you may or may not be aware that there is a change in the guidelines in the offing. So at long last, we have a joint BTS sign NICE guideline that has been released in draft format. The consultation period has closed, so it closed at the end of July, and these guidelines are likely to be released at the Winter BTS meeting at the end of November, and there isn't expected to be very much change. So even though we have this nice one guideline for the country, we do still have GINA, and that says something slightly different, and you might still have some local guidelines. But I think this joining of BTS Sign and NICE, where there were differences in diagnostic recommendations, will be helpful in the way we go forward. So I'm going to gallop through what the recommendations say, because it will affect what your pathway should say. So the first thing that they say, and I really cannot emphasize this enough, is that when we're making a diagnosis of asthma or anything, people should be involved in that discussion and in the decision making about their care. And this is based on the NICE recommendations about personalised care. So it's worth just having that in the back of our mind. I think we are not doing unto our patients, we are doing with our patients. So this is the new draft guidelines. What the draft guidelines tell us we should be doing is looking for signs and symptoms that tell us the patient has got asthma. So they now say reported wheeze. Now, previously it always said healthcare reported wheeze, and that's changed to reported wheeze. So there may be some feedback on that. Noisy breathing, cough, breathlessness, variation of those types of things. Importantly, anything about triggers, the personal or family history of atopy, and then making sure there isn't anything else. So you don't go through a history and automatically jump to asthma. You should be filtering out any other potential diagnosis as you go through. They then go on to say, do not confirm a diagnosis of asthma without a suggestive clinical history and a supporting objective test. Now, that says a supporting objective test, which is interesting, and I'll go through that in a second. And then it tells us to completely be really clear when we make a diagnosis of asthma, what is the basis for that diagnostic code, that diagnosis for the patient. Make sure you code it appropriately. And the reason for that, this isn't new, this is in the old guidelines, but I think it gets missed. And quite often we'll have a child that seems to be growing out of asthma, for want of a better term, and you look back to see the basis on which the diagnosis was made in the first place, and it's often will say cough, wheeze, asthma, which isn't overly helpful. So bear in mind, in 5 years' time, in 10 years' time, you or somebody else might be looking back to see how the diagnosis was made. So make sure it's all documented clearly. What the guidelines tell us then is that when patients turn up, we should treat them immediately if they are acutely unwell. And if we have the capacity to perform an objective test at that appointment, we should do it. And the examples they give us is an eosinophil count, FeNO, spirometry, or peak flow bronchodilator reversibility. So that's a new bit. We've not had peak flow reversibility in the guidelines until then, but that is just in the acute situation. They then say that if you don't have access to the tests there and then, what we need to do is treat the acute situation and carry out the tests when the patient is well enough to perform them. And they do acknowledge that that may be a slightly unhelpful way to do it, simply because we know that if we have a patient with asthma and we treat it appropriately, their tests are going to be normal. So if you have a patient on inhaled steroid, then their FeNO is likely to be normal, as is their spirometry. So, but it is saying that if they are unwell, you cannot just not treat them until you can get the test. So clearly we treat them first. So what tests are we going to do? So children aged 5 to 16, the new BTS NICE sign guidelines are telling us that if we have a history supportive of asthma, we do a FeNO. If the FeNO is over 35 parts per billion, that supports a diagnosis of asthma. And that's all you need to do. So currently the guidelines and QOF tells us we need to do 2 tests. And it tells us we need to do spirometry. QOF certainly says spirometry as your baseline and another test, which might be reversibility, might be FeNO, might be something else. But these guidelines are saying you don't need to do that. What they're saying is suggestive history, FeNO that supports the diagnosis. So that's going to really impact the way your pathway works straight away. It then says that if the FeNO isn't raised over 35 parts per billion, or you haven't got it, then you can do spirometry with reversibility. And it gives you the sort of the parameters that you're looking for. This is children aged 5 to 16. So if you can do spirometry on a 5-year-old, I'd take my hat off to you. I don't think personally that's a particularly effective or efficient way to do it. And actually most children that young can't do it. So the first thing I wanted to ask, I can see we've got 147 people on the call. How many of you, just put a hand up, have got access to FeNO testing? So this is going to be hand straight up and straight back down again. So we've got about 27, 25. Okay, so less than a quarter of you have got access to FeNO testing. So pop your hands back down. That's going to have a big impact on the way these guidelines and the pathways are put into place, isn't it, straight away? How many of you have immediate access to FeNO? So it maybe you've got FeNO somewhere you can refer to, but have you got it there and then when the patient presents when they're immediately unwell? How many of you have got a yes to that? So less of you. considerably less of you. I can see 16 hands at the moment. At this point, I probably will upset you by telling you that in Gloucestershire, we have supplied, and the ICB have supplied Pheno to every practice. So we're really set up for this, which I think is fantastic. Okay, hands back down. How many of you have access to spirometry for 5 to 16-year-olds? So slightly more. I've got 27 hands for that, 26, 27 hands for that one. So still, again, less than a quarter of you. And this will impact your diagnostic pathway for children. Okay, so we've established we haven't necessarily, oh, somebody's not muted. Somebody could just mute quite quickly, thank you. If we don't have access to Pheno, we don't have access to spirometry, how are we going to make a diagnosis? That's actually going to be tricky, isn't it? So what the guidelines then say is that if you've done a Pheno and it's less than 35, you've done some bronchodilatory visibility and it's not giving you anything that tells you the patient's got asthma, but you still think the patient then has asthma, what it's telling us to do then is to do some skin prick testing specifically to house dust mite, or measure IgE and eosinophil count. So we're moving on to bloods, and these are fairly young children. Not many 5-year-olds like a blood test. They then tell us what we do with those results. So if there is no evidence of sensitization to house dust mite on skin prick testing, or if the IgE is not raised, that is not asthma. If the patient has sensitization and or raised IgE and they've got a raised eosinophil, so that's either positive skin prick test or raised IgE and raised eosinophils, then you can make a diagnosis. And if you're still in doubt, you refer. So have a little think about how long you'll refer. Because if you refer a patient to see a paediatric respiratory consultant, if you've got one, or a paediatrician if you haven't, how long is the wait for that patient? Because where I am, it's a long, long wait. So I think there are a few little holes in the plan here. So how many of you have got access to skin prick testing? Stick hands up if anybody has. So more than I thought, actually. So we've got 19 hands up. But still, when you look at the number of people on the call, that's not many, is it? So the objective testing is causing a little bit of a problem when we're trying to diagnose asthma straight away. How many of you have got access for a blood test for young children? So do you do age sort of 5, 6, 7, 8 in practice, or do you have to refer them out elsewhere? Okay, so again, low. So all of these things that the guidelines are recommending aren't particularly available for patients in primary care. So it then talks about diagnosing asthma in the under 5s and acknowledges that it is really hard to diagnose asthma in this age group because it's really difficult to do the tests, and the reference ranges don't really apply to under 5s. And we've all been to the birthday party where the young child has blown out the candle, but actually not blown it out, but evacuated it with quite a lot of spit. And that is the demonstration really that young children cannot perform these respiratory tests. So what do we do with this age group? Well, it does give some advice. It says that you may be, if you think it's asthma, then treat it as asthma, but review regularly. If the children hits 5 and is still symptomatic, what are you going to do then? So if they're still on treatment and they're asymptomatic, does that mean they haven't got asthma? If they're on treatment and they're asymptomatic, are you going to remove the treatment so that you can see if they're still symptomatic? It's quite a hard one. It then says, try to perform the tests from age 5 and attempt them every 6 to 12 months. So are you going to attempt them every 6 to 12 months on treatment and get negative results, or are you going to keep taking their medication away from them? Very difficult, very tricky. But it does say if you're not getting there, refer to the specialist. And I go back to the how long is the wait for the specialist. By the time you get the appointment, it may be that the child can indeed do all of the tests and has or hasn't got asthma. So I think when we're thinking about a pathway, what we're thinking about is where the tests are likely to be performed. And I think we all do things slightly differently, but I think we need to know that where we are working, there is a pathway for those children. And the motorways on the roundabouts on the right are in Swindon. It's called the Magic Roundabout, and it is absolutely horrendous to work out which direction you are supposed to be going in some days. So going back to what I said at the beginning about the bundle of care and the recommendations, the bundle of care recommends that there is access to these tests for children and young people who might have a diagnosis of asthma, and that these tests are performed by people that are trained and competent in doing the tests. So then we've got to think, okay, so how many people have got their spirometry ARTP certification, for example, and have they done the bit that includes children and young people, or have they just done adults? Have you just been given a pheno device and not been told how to do it? Have you not done the training? So I think we need to think around those things that we have to help us. This is the diagnostic pathway for patients with persistent breathlessness in adults, but actually it applies to children as well. And this is an NHS England document. And what it tells you is in that first column where it says clinical assessment, these are your primary care tests. So these are the things you are likely to be doing in primary care. Now, clearly you're not doing the whole list, so you won't be doing an NT Pro BNP in a 7-year-old. You are picking out the relevant tests, but you should be able to do those in primary care. If that doesn't give you a diagnosis, then you should be moving on to the next level of testing, which are your ones that should be happening in your CDCs, your community diagnostic centres. And if you then still don't have a diagnosis, you should be referring on. So that gives you a little bit of a setup of where you think these tests should be done. And you'll see pheno and spirometry sits quite clearly in the first column, which is the primary care column. And then finally, what I wanted to share with you is a pathway that we have in Gloucestershire. So this is our pathway for all age groups. We've not differentiated children and young people from adults because primary care is cradle to grave, and you don't see a paediatric clinician in primary care generally. So, and it's the same for all age groups. This would need to be amended when the new guidelines come out. So this tells you that when the patient presents at any age, you do a full assessment and you do objective testing. Now, clearly it says spirometry and pheno there. That's our recommendation in Gloucestershire. We will be changing that. But you think about differential diagnosis and you've always got those red flags in your mind. That patient is then managed in primary care. And if we get it right, shouldn't need necessarily to touch on any specialist services. So this is about having an effective pathway with access to testing performed by competent, trained clinicians so that we know that the whole pathway from the setup is done as it should be. And if we could manage that bit, I think we would really improve our outcomes for asthma, because along the side of that pathway is obviously the education that goes with it for the patient. I know that sort of went off the pathway, but I think it's really important that you know what the new recommendations are so that you can look at your existing pathway to see whether you're there or not and what you need to do to be able to achieve an effective pathway. And I think the introduction of pheno as your primary test for the diagnosis of asthma is going to really change the way we think about diagnosing asthma in primary care. Thank you.
Wonderful, Carol. Thank you very much. Can I ask Laura, Carol's already got her camera on, and Maddie, you're still with us, to join us on the panel. I have some questions for you. I think all three presentations this afternoon have been fantastic and have actually linked really nicely towards each other, which is wonderful. To all of you, maybe you can choose who's going to go first, but one question from Karen. I thought we couldn't diagnose asthma in children under the age of 5, and we should be calling it viral induced wheeze. Is that still right? So maybe, Carol, do you want to kick off there?
Yeah, so I think the bit that the new guidelines say is this is a very difficult thing to do. And if you're not sure, then don't give that child a label of asthma, because it may not be asthma. It may be a viral induced wheeze. It may be a multi-trigger wheeze. It may be just something to do with infection. So I think if you're not certain, then you hang on before you diagnose. However, some children really do come in at sort of 4 and they've got the very atopic family history, they've got the variability, they're covered in eczema, and it's quite clear that this child has got asthma. And I think what this is saying is be sure and try to prove it as soon as is possible, as soon as the child is old enough to do the tests. Pheno, I think children can do. In fact, I was on a community, we were doing some community awareness events, and I had 2 6-year-olds that managed to perform a really good pheno for me. So you can do it from 5 or 6, natural fact. I think spirometry is a completely different thing, and I think peak flow can be a little bit inconsistent at the best of times.
Laura, from your clinical practice, perhaps you'd like to offer some comment in relation to diagnosing asthma under the age of 5, because I think historically we've always had that drummed into us. But I would agree, Carol, from what you're saying.
Yeah, I think it's really difficult, isn't it? And the fact that it's difficult doesn't make it impossible, but it does, you know, we're relying quite often, I may be going off tangent here, but I think one of the other difficulties is that you're relying on the parents' history. You're relying on lots of other things. My 3-year-old would have some very lovely feelings about his chest. If you asked him, none of them would be helpful. And I think, as you said, Carol, so there's sometimes where it's abundantly obvious, and I think we need to, I suppose, confidently say, this is the evidence. As you've said already, document it thoroughly to evidence your thinking, because like you say, 10 years down the line, you're not going to remember, you know, Jimmy who's coming yesterday. And I think note your findings with conviction, but actually, if you're not sure, there are codes like suspected asthma that you could use as a stopgap, because it is tricky. I heard a story recently that the 5-year thing came because someone had noted in a paper years ago that it's so hard to diagnose that it takes up to 4 or 5 years, and that's sort of where this thinking came from. But yeah, I think it's just you're evidencing your findings as a clinician. I think as a nurse, we're quite often told, you know, if you didn't write it down, it didn't happen. So we're quite solid in that, maybe to the point of pedantry. But it can be a minefield. So yeah, I'd agree with what Carol said. It's tricky, but it's not impossible.
Thank you. And Maddie, from that specialist physio perspective, looking at things perhaps from a completely different angle, maybe you've got something to add there.
Yeah, for the most part, I completely agree with Laura and Carol. In our service, it's very much putting together the pieces that would suggest that it is asthma, and building that picture and documenting it so that the GP and the other services are aware. But of course, then we're spoilt. So we have access to a lot of assessments that we can do. We've got speech and language. We've got FOP, which we can do as well. FOT, sorry. So we're very sort of spoiled that they can do those further assessments and really get to the bottom of it and build that picture a little bit more. So I think if you clearly sort of write down what you've objectively seen, you kind of can't go wrong with that.
Yeah, absolutely. And I think that is across the board. You know, many of us are working in primary care, secondary care, tertiary care, and we've all got access to lots of different diagnostic tools that we could use, and some of us don't have access to any. Now, that leads quite nicely onto a question for Laura and Carol from Amy. We work in multiple community clinics and we're told pheno has to stay in just one place. Do you have a mobile machine that can be moved around easily?
They both, well, there are 2 nice approved pheno machines on the market. They're both tiny. So one is like that big and the other's like a fat iPad, for want of a better description. So they are very portable. The only thing I would say is they are quite delicate. So as I say, we have them at practice level here, and we've had a few when they've gone off for service that have been cracked, where they've been, I think the nurses have been a bit heavy-handed with them. So if you're moving them, just be careful with them.
Yeah, I was going to say the same. They're quite small, aren't they? They're quite portable. But I'm a very clumsy nurse, and I'm always very, very careful when I handle the pheno machine. Yeah, I guess it would be looking at what devices you're using and whether it's more of a case that people are more concerned about the breakability than the moving. Yeah, but yeah, we certainly don't have pheno in my patch. We don't consistently have pheno anyway. We have it in most of the hospitals, but certainly not in primary care. So yeah, it's an interesting problem, isn't it? You know, where do you put the resource?
Certainly is. And I think possibly the other thing in terms of relating to resources particularly, and this is a question that I think has featured a few times in the chat, how have you secured funding, Carol, for all of your PCNs to have pheno?
It's not our PCNs, it's our practices. So
well, even more so then.
Absolutely. So so first of all, we're a rural community. So if it's in the neighbouring practice might be 25 miles away. So it's not helpful. In actual fact, I did a project in one of our localities with the Accelerated Access Collaborative when they were looking to increase the availability of pheno in practice. So I've been doing pheno for about 20 years, and I was doing a specialist referral clinic for any practices within the locality. And I'm going to retire at some stage, so I wanted to roll that out. So we put a bid together to the AAC to do the education. So all of the nurses came and sat in on the clinic, and to provide the machine. So that was in one of our locality. When we looked at our local enhanced service, and we actually did some of it through our CDC bid, there was an equity question. So the area I work in is not our deprived area, and they had access at practice level. So we had to match that across the ICB. So we managed to get some of it through in our CDC bid, but the ICB are paying to do that, and they've agreed to do that. And we pay for the servicing, we pay for the initial machine, and we pay a local enhanced service rate of about £35 per test that's done. And the idea of that is that will cover the consumables, which cost about £3.
Okay, so link to Pheno once again. This is another question that has come up. If a child's admitted and they're presenting acutely unwell and admitted to the hospital ward, should we be doing Pheno at that time?
I would say if they haven't got a diagnosis, absolutely. So if it's the first presentation, then yes, it's very helpful to do that whilst they are steroid naive. So what some of the practices are doing where I work, I know they've got it at practice level, but as soon as somebody presents, if they've got a likelihood of asthma, they immediately have a Pheno done so that they can then start their treatment and feel better, but not affect the results.
Okay, that links back to your presentation about the Pheno can be completely normal if somebody's already on treatment. Okay, yeah. Maddie, can you describe what good nose blowing is?
That's a really good question. So I guess good nose blowing would be sort of encouraging children, especially if they have rhinitis symptoms or a blocked nose that's really persistent. I'm not just talking about, day-to-day mildly snotty child. If you're struggling with those sinus symptoms and maybe they're already on treatment, getting the child to blow their nose when they're quite young, okay, and practicing that, and making sure that they're doing it sort of regularly and effectively. So some children will sort of, suck everything back all day, every day, and it's kind of just breaking that cycle a little bit. And sometimes we'll incorporate sort of different angles and things like that. So we might get them to really lean forward and blow their nose or tilt their head left and right. Just really sort of frequently getting everything out rather than sort of sucking it all back, which might cause them to clear their throat a lot and irritate sort of the back of the throat, and cause them to do a lot of throat clearing as well, which can impact the pattern of breathing. I hope that's helpful.
Wonderful, thank you. Now, we have run out of time. Can I ask all three speakers if you have a few minutes to spare just to answer some of the questions in the chat, because there's lots of questions there. And lastly, to say a very, very big thank you to all three of you for presenting at this nursing webinar as part of Ask About Asthma Week. Grateful that you've given up your time, and there's been some really interesting, insightful presentations. So thank you very much. Before people leave, there is an evaluation in the chat. Please do fill that in because it helps us to plan for next year's events and moving forwards. So thank you all so much for joining us today. Enjoy the presentations and the rest of the sessions that are around all week. This week there's lots to tap into, and there's obviously the conference on Thursday. If you haven't yet registered, please do try to. So thank you once again, Laura, Carol and Maddie.